Hi, I'm Tricia Ward from theheart.org Medscape Cardiology. I'm at the 2024 American College of Cardiology Scientific Sessions in Atlanta, where I'm joined today by Dr. Tony Lamas. He is Chairman of Medicine and Chief of the Columbia University Division of Cardiology at Mount Sinai Medical Center. Welcome, Dr. Lamas.
Thank you, Tricia.
So you just presented the TACT2 trial on chelation therapy in patients with diabetes and prior MI. Can you tell us the top-line findings?
Sure. The top-line findings are that the study was negative, did not show any benefit for chelation in our U.S. and Canadian patients who had established coronary disease with a heart attack and also had diabetes compounding. Now, what is chelation? Chelation is a chelating agent is a chemical compound that has a particular shape with a pocket. So it's like a baseball mitt with a magnet in it. And the one that we're talking about is EDTA, which is ethylene diamine tetraacetic acid, or edetate disodium, which is the FDA designation of it. So in the original study,
That's the TACT1
that's
study.
TACT1 study, that ran from 2003 until 2012. And this study has exactly the same design. We identified patients who had prior heart attack, reasonably good kidneys, at least 50 years of age, and were not smokers. The reason they couldn't be smokers is that cigarette smoke has a lot of lead and a lot of cadmium. So we randomly assigned them to receive 40 infusions of the chelation or 40 infusions of placebo. And everyone thought that this study was going to be negative. And in fact, I was shocked when the study turned positive. And then had to do a lot of backpedaling and scrambling to figure out by what mechanism could this have been. Well, it turns out that it was obvious. EDTA chelates lead and cadmium. They're both vascular poisons. They're vascular poisons because they take the place of essential metals in our body. We had this surprise result with an 18% relative risk reduction in all comers with a prior heart attack, statistically significant, and a spectacular 41% relative risk reduction in the patients who had diabetes. FDA said, well, this is very interesting. Why don't you do it again? So a couple of years pass and TACT2 starts. First patient is randomized in 2016. Randomized 1,000 patients. Same team. Same protocol. Same data coordinating center. DCRI, Duke. Same clinical events committee at the Brigham in Boston, and then at Stanford. Same batch of EDTA made by the same manufacturer.
So now one of the reasons you think the result was different is because of the lead level.
Okay, so why was it different? We realized that in the decade plus that occurred between the start of TACT1 and the start of TACT2, the lead levels in the United States and Canada have been dropping rapidly. We don't have it from TACT1 because we weren't supposed to spend any extra money. Okay, so NHANES, which is a national survey, it's representative of the U.S. So age 50, diabetes and vascular disease, their lead levels were 17 in TACT1. In TACT2, their lead levels were 10. And the people that we randomized, because we were smart enough now for TACT2 to have a trace elements lab, was 9. So you see that what we are now doing is the equivalent of trying to reduce cholesterol in people who don't have a high cholesterol.
But the chelation did actually work in terms of reducing.
Right. So the next step is, okay, well, did your chelation work? If you look at blood lead level is a representative of your total body lead burden. And that went from 9 to 3. So over 60% reduction. The drug works. If you look at cadmium, the total body burden of cadmium is thought to be best reflected by cadmium in the urine. That didn't change so much, but still, when we gave the infusions, the cadmium excretion increased by about 600%, which means that we have a lot of cadmium in our bodies. Okay, so the EDTA worked. The level of lead was very different. And in fact, when you look at the epidemiologic studies, there's very little data that tells you how much damage to the vasculature a lead level between 0 and 10 is going to do. And so our hypothesis, and I want to emphasize that this is a hypothesis. You do two things exactly the same. And what's different is your target of therapy, which has been going down. The public health doctors have done a great job. The politicians even have done a great job. And so we now find that we can't detect a benefit. Now, it's conceivable that if we did a 10,000 patient study or something, we could.
And in fairness, I mean, this is a quite time-intensive intervention.
It is really tedious. It's 40 infusions. Each one lasts 3 hours.
And that's weekly. So
yeah, once a week you're expected. We tried to be realistic and as kind as possible, so nobody does 40 weeks in a row. People want to visit the grandchildren in the summer. We just try to finish it within a year.
And what was the compliance?
40 infusions were received by 68% of the patients, which I actually think was spectacular. And 20 infusions were received by 78%. Pretty much on the nose, exactly like TACT1. So it should have worked if the premise was correct.
Well, now, do you think the takeaway from this is that we've done a good job with environmental toxins?
I think that we've done a good job with lead. Lead has made it into the legislature and into the law much better than others. Much better than cadmium, for example, much better than arsenic, etc. And EDTA is pretty specific for lead and cadmium. I do think that we need a stronger cadmium chelator. We still have, like little events like Flint, Michigan, kind of a little big event. Newark, New Jersey, Baltimore, parts of the South. What happens is that lead, when you look at the worldwide map of lead levels, lead is seen where there is poverty.
But you mentioned that you actually had a site in Flint, Michigan.
We had one site in Flint, Michigan. They enrolled 2 patients.
But isn't that kind of part of the problem where this solution, the very people who would need it are probably the very people who don't have 3 hours a week to spare?
Or the way that I look at it is that the people we enrolled were individuals who had a cardiologist who was participating in the study, which means that they probably had a job, health insurance, etc., or they were retired, and then they had the time. We ended up not selecting patients based on their lead level, because not having had the lead levels in the first, if I had to do it again, of course, I would figure out how to find the people with the highest lead level, and it might be outside the U.S.
And I think some clinicians with things like environmental toxins, it's a little overwhelming. They feel like, well, that's maybe something society at large has to address rather than me, a physician in a clinic.
Well, you know what? Hypertension has to be addressed on a societal basis. Obesity has to be addressed on a societal basis. And yet people sit in front of me who are obese hypertensives, and I address it in an individual basis. This division between this is them and this is us, that doesn't really cut it. we now have this specter of microplastics. Now that's a tough one. We're not even quite sure how to measure it, but we do know that they exist.
You're referring to the recent paper.
The recent paper showing that if you have microplastics in your carotid atheroma, you're more likely to have cardiovascular events. Well, we need to figure out how to measure that. And we also need to figure out how does the body get rid of it, or does it? So, for example, I haven't looked into this in detail, but one of the things that I need to do, obviously, is look at urine. Does it come out in the urine? I don't know that.
So is that your next study? Plastics?
No, I need to. No, my next study is to finish the revisions of my paper so I can get it published.
And is there anything else you'd like to say? Because you rewrote the AHA statement on metallic.
Yeah, right, and it's all correct.
It's still correct.
Yeah, it's still correct.
Okay, well, thank you very much for your time.
Thank you.
This is Tricia Ward signing off for Medscape.